Welcome to Human School. I'm your host, Dr. Patil Armenian. After 4 years of college, 4 years of medical school, 4 years of residency, and 2 years of fellowship, I thought I was done. I did my time, got my degrees, and now I was just gonna live life. Well, think again. Some of my greatest schooling has come after my formal education was complete, and it keeps on coming. Join me at Human School, where we can learn together. I'm an emergency physician and medical toxicologist working at a large teaching hospital in California. I'm also a mom, wife, sister, daughter, and friend. Whether you work in healthcare or not, you too lead a busy life. Together, let's work on how we can thrive in all of our real-world roles. On this podcast, we'll dig deep into what it means to constantly learn and evolve, to be human. Every other week, I'll share some of my personal stories, interview inspiring people, and offer tools to help you learn more about yourself. Being on the front lines in the ER, you learn a lot about life and death. And though my philosophies were born in a busy emergency room, they can apply to anyone trying to live a joyful life here on Earth. Please listen, share, and subscribe to this podcast, available on Apple Podcasts, Spotify, or wherever you get your podcasts. Follow me on Instagram at Human School Podcast, and feel free to let me know what topics or guests you want to hear about. And if you like the podcast, don't forget to rate and review it. Hi everyone, and welcome to Human School. Today I'm going to be talking about thin slicing, rapid decisions, and intuition. As a disclaimer, I want to say that my stories come from the ER, so they can be intense, sometimes sad, and occasionally about death. So if you're not in a mental space for that, save this episode for another day. Also, I use the terms ER or emergency room and ED or emergency department interchangeably. It's really because most people outside emergency medicine know it as ER, even though we all know it's not just a room. I want to start with a story about triage. The ER where I work is larger than a football field and beyond busy. Lately, we're seeing 350 patients a day, on track to see 120,000 patients a year. Unfortunately, we're not special. All emergency departments are super busy nowadays. So a lot of new systems have been put into place over the years to try to streamline care and make things more efficient. I heard someone recently say that capacity is the new pandemic. And it's true. We just don't have the space for all the patients we have. Now, this is a big topic for another day. If you guys are interested, I can definitely talk about it. But it is very interesting how busy all emergency departments have become in the United States. Over a decade ago in my ED, we started a provider at triage system. How is this different than traditional triage? The traditional way of doing triage in an American ED is that you walk in, state your complaint to the triage nurse, for example, abdominal pain or chest pain. Then they take your vital signs and decide what part of the ER you'll wait for. Once you're in your assigned room or bed, a doctor will see you, speak to you, examine you, and then decide on the next steps, which may include a procedure, tests, medicine, or other interventions. The triage nurse has a very difficult job because they have to quickly decide how sick someone is, which then determines how fast they need to be seen. In my ER, we still do this type of triage for ambulance patients, and for walk-in patients, we use a newer system called provider at triage. How does this work? Well, when a patient walks in, they're again seen by the triage nurse, and if they're visibly very sick, immediately get sent to a room inside. If not, they're placed in one of 5 cubicles in an area that's staffed by multiple doctors, PAs, NPs, RNs, LVNs, techs, an EKG tech, a phlebotomist, a Spanish interpreter, and a clerk. It's a lot of people, but all of the team members are needed to run this ship. A lot of patients go through this area. There, within minutes, one of the doctors will see the patient, examine them, and get tests and interventions started. At that time, we also decide what part of the ER to assign the patient to. In our case, the ER is divided into different zones based on acuity, which in plain English is how sick someone is. So, for example, our red zone is for the sickest of the sick, whereas green is a little less sick, and then we have other areas that are a little less sick than that. Many times we have no beds anywhere, and so I'm always talking to the nurses to help prioritize who needs a room first. We work as a really close team with the nursing staff, and there's constant communication about who needs an IV, for example, or who we're mutually worried about. If you've ever been to an ER and feel like you've been waiting longer than others who are being roomed before you, that means that someone else is much sicker than you. That can be so frustrating, but it's the very nature of the concept of triage. It means we have to take care of the sickest first. It's not glamorous being out at triage. It's not the ER you see on TV shows. A lot of action is happening, but not the life-saving, heroic efforts you think about when you think ER. In fact, some doctors hate being out there. You'll hear comments like, "Why did I go through all that medical training just to do triage?" Or, "I'm not even making a difference out here." And I agree, it's not easy, it's tedious, hard work, but it's needed to keep the place moving, and it's its own interesting cognitive challenge. Provider at triage as a general concept is not going anywhere, so if you're in training now, you will likely encounter it wherever you end up working. To me, good triage is one of the most difficult skills of emergency medicine. In 5 minutes or less, you're making major decisions about a patient's care, and it's a huge challenge to pick out the few sick patients from many who appear seemingly well. I personally don't mind being out at triage for this reason. Now, one day, I'm out there, and I saw a middle-aged man walk into main triage unassisted. I'm pretty sure he drove himself to the hospital that day. Typically, the nurse at the front desk asks for a quick chief complaint and gets an initial set of vital signs. Then, like I was saying, the patients wait in a row of chairs to get placed into a triage cubicle to undergo more thorough questioning and a brief physical exam. The front desk triage nurse was super busy and overwhelmed, and so wasn't able to get a set of vital signs on this patient. I hate to admit it, but sometimes I try not to look around too much when I'm out at triage because it can get overwhelming just with the sheer quantity of people out there. Why I decided to look around at that moment, I'll never know, but I looked at the row of chairs against the wall and saw that one of our most experienced nurses was checking this patient's blood pressure. Nothing looked abnormal, and I can clearly see the vitals from 15 feet away on her machine. They were totally normal. I walked over to her and said, "Why is this patient here today?" And she said, "Chest pain." He looked calm and comfortable and wasn't sweaty or having any difficulty breathing. I told him something along the lines of, "We'll see you soon, don't worry." Then, for no apparent reason, I told the nurse, "Get a gurney now. Put him on a gurney and let's get an EKG and send him to red zone." That area that, like I was saying, the sickest of the sick. I very rarely say that someone needs to lay down on a gurney immediately, and it was such an unusual and forceful request from me that it immediately happened. The nurses and tech had him laying down on a gurney in less than a minute. I put my hand on his left shoulder and I said, "We're going to get you to a room now." And he said, "Okay." I didn't move my hand. While they were opening the door to usher him inside to a room in the red zone, I felt a chill go up the hand that was on his shoulder and through my whole body. Without my brain thinking, my mouth called out, "Does he have a pulse?" And I felt his neck for a pulse that was not there. I called out, "Start chest compressions," and someone began compressions while we wheeled him to a resuscitation room. He was pronounced dead about 30 minutes later after the team valiantly tried to resuscitate him. Looking back, were there any signs that led me to think he was sicker than he looked? The first thing was that I was paying attention. The second was that our most senior triage nurse was checking vital signs on someone the physicians hadn't seen yet. It was just kind of unusual to see that pattern for some reason. It was unusual for her to do that, so maybe that's what caught my eye. Was it thin slicing? Was it intuition? How did I make that decision without even thinking about it? Like I opened my mouth and words came out to get him a gurney and move him to a room now, as if I knew something was about to happen, but I didn't. What's interesting is this story is not special. If you've worked in an ER for some time, you too have a story just like this. How does this happen? Every day, we make hundreds, if not thousands, of decisions, both big and small. Whether it's at work, at home, during a commute, or at play, we're consciously and unconsciously making fast decisions. As you know by now, I speak through the lens of emergency medicine. But a busy ER has many parallels, not just to other sectors of medicine, but many other workplaces. Really, any place where rapid decision-making is needed. I used to work at the Daily Bruin, the student newspaper at UCLA, where I was an undergraduate. For me, the energy of that newsroom felt identical to the emergency department years later. A place full of time-sensitive information, deadlines, drama, and the satisfaction of getting the job done right. You can apply the concepts I'm going to talk about today to any field you work in. Now, what is medical decision-making specifically? Technically, it's the cognitive pathway that allows you to make a diagnosis or come up with a treatment plan from all the information sources you have and taking into account all the competing possibilities. That's competing possibilities for both the diagnosis and the treatment. And the term competing possibilities implies that you have to know a lot of options in order to whittle it down to your best plan for diagnosis and treatment. So all the learning and studying you do in med school and residency, that's the knowledge base that you're creating right there. In the ER, patients are usually unknown to us. It's often our first time meeting them. There are a high proportion of unstable patients or the potential for instability. Patients have to be treated quickly and with high levels of diagnostic uncertainty, a high decision density, and high cognitive load. There are many interruptions and distractions. The bottom line is we're making a lot of decisions in a short period of time while dealing with ambiguity and many other things happening at the same time. Some of the questions you can think about now and after this episode are the following. 1. Do you use your intuition to make decisions? 2. Do we make decisions the same way all our lives through every level of training? 3. Do experts or novices use intuition? 4. Do experts or novices use protocols? 5. Who is an expert? And 6. How do we make rapid decisions? And I'll put these in the show notes too if you want to refer back to them. I think everybody's going to have their own answers, and I'm just going to talk about some of my theories on them. Let's start by talking about intuition. Some other terms for intuition are gut feeling, sixth sense, spidey sense. I feel like we say spidey sense a lot in the ED. Whatever name you give it, your intuition is a muscle that needs to be exercised and developed. Early in my emergency medicine training, when I was a junior resident, I used to think that my professors had magical powers. Like, how could they walk into a room and know a patient was about to go into cardiac arrest? But really, no one has magical powers that give us the ability to detect disease and injury. Rather, we have to learn a lot, but somewhere along the way, as experience builds, your sense of knowing also builds. And one day, you realize you know in an instant if someone is sick or not sick. The concept of intuition wasn't something formally taught to me in medical school, but a lesson I learned many times from the nurses I've had the privilege to work with. Very early on in my career, I think I just finished my fellowship training and was working one of my very first attending shifts in the ER. An attending is the supervising doctor, and I teach the residents, or ER doctors in training, at the bedside while taking care of patients together. A young man was placed in one of our resuscitation rooms, and the resident and I went to go see him. He was well appearing and had had some chest pain, which had already resolved by the time we saw him, and he had a normal EKG and normal vital signs. I'm not going to lie, my first thought then was, why are you taking up our resuscitation room? Let's get him to a different room. He'd been placed there because his close friend was a hospital executive, and the next thing I heard was that a cardiologist had already come down and was going to take him to the cardiac catheterization laboratory. The executive had called the cardiologist. We hadn't. I felt there was no need for that invasive emergent procedure, but who was I to try to stop this quickly moving train? Just then, one of our most experienced nurses walked out of his room and pulled me aside. She said, "I checked his blood pressure in both arms, and they're 30 points off from each other." We then stared at each other wide-eyed, and I asked her, "Why did you do that?" Genuinely, like, what about his story or exam made you think something was wrong? And she just says, "I don't know. I felt like something was off." Okay, so what does this mean in English? Well, if someone has chest pain and then very different blood pressures in their arms, one diagnostic possibility is a tear in the aorta, the largest blood vessel in the body. We call this a ruptured aortic aneurysm or an aortic dissection, depending on the exact nature of the injury. That gave me the rationale I needed to then walk up to the cardiologist, who was about to take this patient up to the cath lab, and ask him to hold off so that we can take this patient to the CT scanner right now. And I made sure we already had the scanner open and it was, 10 feet away. On the CAT scan, we can clearly see that the aorta did indeed have a dissection or tear, and emergently got this patient to the operating room with the specialist surgeons. He had a great outcome. I've had similar cases since then that didn't go as well because the tear had progressed too much by the time they arrived through our doors. Time is of the essence. That nurse saved this patient's life. Her experience was a very important factor. The more sick people you see, the more you recognize sick. The more healthy people you see, the more you recognize healthy. The more resuscitations you work on, the more you know how to control the situation and work with your team. Just recently, I was working a shift when one of my favorite nurses came up to me and asked if I could see a certain patient next. All she said was, "Something's wrong with him. He doesn't look good." Here's a hot tip for all ED providers. If an ED nurse says something's wrong with a patient, just drop everything and go have a look, because they're usually right. So I immediately walk over and saw the patient and totally agreed. We moved him up to a resuscitation room, and I called over the junior resident who had already seen the patient. Coming up with a plan together, we quickly got him to the CT scanner and diagnosed him with massive pulmonary emboli, which were successfully, emergently removed by our interventional radiologist. Actually, it was a Sunday night, and the interventional radiologist was at home. It took a fair amount of discussions until he came in, but it ended up being a total save. The diagnosis would have been delayed by hours had it not been for that nurse, who quickly and assertively conveyed her life-saving assessment. When the blood vessels in your lungs are completely filled up with blood clots, as they were with this patient, you may not have hours to work with. I've talked to a lot of our ED nurses about using their intuition, and some have even said that they were encouraged by their preceptors in nursing school to use their intuition about patients. That's a word that I never heard in all of my medical training. Or is it a layer that gets added on later, something only an astute mentor would mention? In the beginning of training, you're learning all of the algorithms, protocols, and lists of diagnostic possibilities that eventually become your safety blanket. We emphasize the ABCs, which in our world are airway, breathing, and circulation. We emphasize the algorithmic trauma assessment, resuscitation pathways for all ages, protocols for sepsis, acute strokes, acute heart attacks, acute heat stroke, and the list goes on and on. You see a ton of patients, immediately assessing them and coming up with diagnostic possibilities and plans for them. You become familiar with the local paramedics, the nurses, every person on the team. With each interaction, your subconscious files away information. And then one day, you don't even realize you're doing it, but you get a good chunk of your patient assessment done in a few seconds. You just know who is sick and who's not sick in an instant. Again, no one is born with this. It comes with experience. To break this down further, let's discuss the two main systems of reasoning. System 1 is fast, intuitive, and heuristic. This is recognition primed and acquired largely through experience. These are reflexive and skilled actions, but they're vulnerable to bias and they're error prone and sometimes too fast. System 2 is slow, deductive, rule-based. Uses analytical judgment with deliberate, rigid actions. Bias is minimal with few errors, but it can be slow and expensive. So one good example of this is if you order every test on everyone in the ER. It's like, yeah, you're not going to miss something. It's going to be very safe, but it might not be the right track. Really, the best decision making is going to be a combination of these two, because we don't want to approach people with any type of biases, but we also want to use all the bits of information that are available to us. And that can include your first intuitive hit on someone when you walk into a room of, are they sick or not sick? Now let's break down the concept of thin slicing for a moment, because I mentioned that earlier. Malcolm Gladwell does an excellent job in discussing these concepts, actually all these concepts, in his book Blink. I think Blink is necessary reading for anyone in any sector of emergency medicine. One concept Gladwell discusses is thin slicing. Thin slicing is the ability of our unconscious to find patterns in situations and behavior based on very narrow slices of experience. This is a system 1 way of reasoning and works best with the most experienced. It's like the intuition of experience. In his book, he tells a story about how there was this really excellent fake classical Greek sculpture that almost everyone thought looks real. And then a true expert just came in 1 second was like, that's not right. And so that's what thin slicing is, in 1 second knowing whether something seems right or not right. Now, this system can be very useful when trying to immediately evaluate if a person is sick or not sick. I find that the initial impression of a patient is exceptionally valuable, and so I try to approach each scenario with a clear mind so that I don't get a clouded initial impression. Even if it's just for 3 seconds, I try to approach each new patient with a fresh mind. Clarity is key. One tool that I use to maintain my clarity is lists. I always have a paper list with me on shift, and I'll write each patient's name with a list of what I'm waiting for or what to do, so that I'm not trying to keep 100 things in my brain at the same time. You have to offload some cognitive things in order to have clarity. Otherwise, you won't properly see the patient staring right in front of you. One more thing. Remember, your report is someone else's initial impression. So when you call a consultant, or if you're a medic giving a report to the ED team, those words are all important. Like how I had to properly convey to the interventional radiologist that the patient with the blood clots in his lungs needed the life-saving procedure that evening, and not later, not the following morning. We didn't have those hours. And then on the receiving end, you always have to do your own assessment without being biased by others. Now, as you can imagine, since intuition is based on situations we have been in the past, it can be biased, and it can introduce problems as well. So we can't only rely on intuition. So bottom line is we can't get to this point without knowing protocols and algorithms inside and out and seeing tons of patients. As Malcolm Gladwell says in one of his other books, Outliers, it takes 10,000 hours of intensive practice to achieve mastery of complex skills. And if emergency medical care isn't a complex skill, I don't know what is. I reached 10,000 hours after I was already finished with a 4-year residency program. If you work 12-hour shifts at 12 shifts per month, it's almost 6 years before you get to that level, and you can do the math for whatever field you work in. One more concept I want to circle back on is the concept of the cognitive load. This is the weight on your working memory. And this is why protocols are useful. So how much information can you retain in your short-term memory before you forget something? How many details can you keep track of? That is one of the great things that I love about protocols, algorithms, clinical decision rules, and checklists, just like the paper checklist I mentioned earlier. Because with those things in place, we can structure spontaneity. And I love this concept of structuring spontaneity, because simplifying complex medical decision-making into a set of rules actually frees up the rest of your brain to make other decisions. You're reducing cognitive load with your algorithms and protocols so that if something is different or weird or just off, you'll notice it. And you have to notice those things. That's why we're not robots doing emergency medicine. We have to free up our brains so that we can notice the things that are off, because that is when you're going to get the weird diagnosis or know that something is about to happen with our patient. And, it's very creative. Some of the best artists actually work this way. They work with structure. And just because you have structure doesn't mean you don't have creativity. And that's where you're going to find that hidden spark in your cases. I want to end with one more story about being present. Because sometimes we're just kind of stuck in our own heads while we're at work, and you just have to look around sometimes. This was sometime in the last year. I was in a zone of the department that I really wasn't assigned to be in. I was just there to say hi to a friend that was working. And as I was walking back to the zone I was assigned to, I happened to look up, and there was a patient in the hallway who was just staring back at me. He didn't say anything. He was just looking, and I actually kept walking. And I went a few steps, and then I walked backwards, and I just looked at him, and I said, "Are you okay?" He actually was just kind of frozen, staring at me, and he had a food tray in front of him, but his hands were just down. He wasn't doing anything extra. He was just staring at me with wide open eyes. And then I was like, "Are you choking?" And he, again, couldn't respond to me. And immediately I just called out, "Can someone help me? I think this patient is choking." And so a nurse and one of our residents ran up. We kind of pulled him up and forward. I hit him on the back real hard as the resident actually punched him in the stomach because he was too big for us to do Heimlich maneuver. So I know I'm laughing. It's not funny, but it was just a very dramatic scene. Long story short, this giant carrot flies out of his mouth, and he immediately starts talking, just apologizing first, like, "I'm so sorry." And I was like, "What are you sorry for? You were choking." And he was back to normal. But if I hadn't walked past and just noticed him just staring at me, I wouldn't have even been able to help him. And I think he would have choked, and maybe he wouldn't have gotten help in time. But it's just a reminder to just sometimes look around and be present, because you never know who needs your help around you. The bottom line of all this is the following. The best rapid decision making comes from combining the two systems of clinical reasoning, analytical and intuitive. If you're aware of your own thought processes, you may make better decisions. Stay present and clear so that you can work at your best, and make sure to look around sometimes. Thank you everyone for listening, and I'll see you next time. Please like, subscribe, share, and download the podcast. And again, you can find us at Human School Podcast on Instagram. I'd like to thank Dr. Zac Efron for the theme music. And I'd just like to make a general disclaimer that any of the institutions I work for, including Community Regional Medical Center, UCSF Fresno, and American Ambulance, have nothing to do with any of my thoughts or opinions. And so we'll kindly leave them out of this. Thanks everyone. See you next time.